Till now, the commonly performed incisional surgeries remain trabeculectomy. And yes, now tube shunt surgeries have also picked up and have become a fairly common surgery. So whenever we are talking of trabs and tubes, we refer to this study that has been done, the TVT study or the tube versus trabeculectomy study, which has also published their 5-year results and outcomes. And it is a well-known study which is authenticated, and it compares the efficacy and safety of tubes, that is, they use 350 millimeter square Barwells versus Trab in 212 eyes. But none of these eyes were virgin eyes. They all had prior surgery, which was either a cataract surgery, or it was a failed Trab, or it was a combination of a cataract and a failed surgery. The treatments went in favor of tube surgeries, saying that there was higher success rate with tube surgeries and lower reoperation rate in tube patients. There was no difference in the vision loss, IOP reduction, and supplemental IOP lowering medications in either group. So as a result, the TVT study also showed that there was a shift in practice pattern towards tube surgery. What does that mean? Tubes is the new gold standard. It is the thing of superior quality and it is the point of reference now all over the world? Maybe not. Because the TVT study, like other studies, also has its limitations. If they had probably selected virgin eyes who had not undergone any surgery and underwent trabeculectomy, the results would have been probably in favor of the trabs. Whereas if they had included secondary glaucomas with poor surgical prognosis, maybe the results would not have been favorable in case of a lot of tube surgeries. The inclusion and exclusion criteria and selection of patients do make difference to different studies. Like we have seen that Wilson MR also did a long-term study. It was a 3-year study with about 163 patients where they compared the results of Amit glaucoma valve with trabeculectomy. But their results showed after 3 years, actually 31 months, that IOPs and cumulative probabilities of success was comparable. In TVT, we see that reoperations for glaucoma in the tube surgery was repeat tube surgeries, cyclophotocoagulation, but no trabeculectomies. Whereas in the Trab studies, repeat Trabs were done along with tube surgeries. So what happens when tubes fail? The option remains repeat tubes, cyclophotocoagulation by endocyclophotocoagulation or diode, and shunt revision by excision of the encapsulations. But we do not actually get a chance to do a repeat Trab after a tube surgery because there is a lot of scarring that has taken place because of the surgery itself. Now putting in an additional tube, is that the end of the story? Unfortunately, SHA AA shows that even after a second tube, the failure rate can be pretty high, along with serious complications like tube exposure, chronic hypotony, decompensation of the cornea, diplopia, etc. And the more number of tubes, the more ocular surface irregularity and disorders, lowering the quality of life of the patient. Dr. Gede of TVT study and Dr. Chen in 2019 says that definitely the popularity of tube shunts has grown and valuable information has come up to guide surgeons in the use of tube shunts, but the higher risk of complications, surgical complications, still remain. So where are we now? Trab still remains popular as a better option for masses in India. It requires simple instrumentation and is technically simple. And as a surgeon gains more and more practice and understands what works best in his hands, it becomes a relatively predictable surgery. It is cost effective. It definitely lowers IOP. Long-term studies of about 10 years on Asian population by the stalwart Dr. Ramanjit Sihota has shown that it is efficacious in lowering IOP and also stopping visual field progression. And on top of that, if a trab fails, we have options of doing repeat trabs. We have the option of tube implantation, plus minus bleb revisions, and cyclophotocoagulation. All of us who are practicing glaucoma realize everything said and done, it is the person who is sitting across the slit lamp in front of us, the patient, who matters. So in a progressive glaucoma, in a virgin eye, with no significant cataract, what would be the choice of surgery? Tubes, because that's what DVT is showing, or I think most of us here would agree that we would definitely go in for a trab in this. On the other hand, with a case scenario like this, an accent field rigor, cornea decompensated, PK done, now sitting in front of us with intractable secondary glaucoma, congestion, extensively scarred conjunctiva, uncontrolled with supplemental anti-glaucoma medications. What would be our choice? I think there we will definitely think of tubes. So decide how to proceed by weighing the risks and benefits of the patient sitting in front of us to help that sick eye. There is no one rule for all. There is no one size that fits all. But if a patient sits in front of us where we have the option of doing either a tube or a trab, I think that in our present situation in India, we would still opt for a trab, and that is the more popular surgery till now. Thank you.
Thank you so much, ma'am. So that was a very... So that was an excellent talk regarding the trabs and tubes. The controversy still remains because ma'am has left the floor open that, let the choice be made on the merit of the particular patient. But in the Indian scenario, like ma'am pointed out, considering the economic consideration as well as the availability of the devices, probably trabs are still there. It is still the gold standard and it's here to stay. So any questions from the audience or any comments from any of the panelists?
Tubes there.
Still, trabs are the first choice. Like how you said, we decide based on the condition of the patient. Any patient which has already had a retrab, one-night patient with high pressure, already had a PK, angle abnormalities, multiple PAS, multiple surgeries, retinal surgery already done, neovascularization probably suspicious because of the posterior segment. These are the indications they go directly for a tube. Otherwise, trabs are still our first preference.
So what is the tube that you usually use, AMID or Avid?
AMID.
So, and
I have a question like, with a failed trab, what will be your choice? Another trab or a tube?
It depends on what type of trab it is. If it's something with a secondary glaucoma where I have already tried with a trab, I would go in for a tube. Or say it's an NVG where they have put in intracamerals and we have got rid of the NVIs for the time being, maybe I would think of a tube. But if it's a plain and simple case of glaucoma where I have failed with one trab, I usually opt to do it nasally, so that I have space for 2 more trabs superiorly. I would definitely go in for a second trab. It all depends on why the first trab has failed.
So a question for Manishda, because I know Manishda loves AGVs. So if a Ahmed glaucoma valve fails, do you go for a second valve or do you try to salvage the bleb, like in a bleb needling? Have you ever tried that?
I have tried bleb needling, but they don't work for long term. Like short term is fine. In AGV patients.
Yeah,
bleb
needling in AGV or revision of the bleb in a valve.
A revision of bleb, personally, I've never tried in an AGV patient, but bleb needling I have tried in a few cases. It gives you a short-term IOP control, but then over time, again, the cyst form and the pressure increases. So when the AGV fail, a second AGV is generally a better option. Of late, I'm considering using a non-walled in a case where the first one is a walled and second one can be a non-walled. Maybe gives you a, and generally we know the non-walled tends to give you a better IOP control, although the surgical time is more, takes more time to start working, but gives you a better IOP control. That cyclophotocoagulation is again an option if you can do a limited in a step-up approach, maybe do a 90-degree and then again repeat it again.
Has anybody tried the endocyclophotocoagulation? Because now it's available.
I'd love to try if I have it, but I don't have it. But I had one patient where post-penetrating keratoplasty and AGV was done, it failed. Now, in that case, we were totally lost of all the options. So I referred the patient to Bangalore to Dr. Gauri, who is having, and she did it, and the patient is doing well.
Because I've also referred a few patients to LV Prasad, and they've done an endocyclo, and they are doing well.
We had a
we had a
demo machine
demonstration.
for some time. We in Barakpur, Orijit has done a couple of cases, I have done. The procedure seems to be pretty simple. Now, unless you're doing it regularly, the procedure is very quite...
And regarding bleb revision in case of Trab, do you go for the external conventional approach, or like Dr. Dipanjal Pal is trying the other one, where you go in through the anterior chamber and then emerge through the ostium
No,
outside?
you're saying internal bleb
Yeah.
leakage.
Do you think that that probably is a better, less invasive way to go?
I personally feel that if it is a late attempt, then it is not better to go internally. Internal revision helps when, for some reason or the other, we have not established the fistula well. Somehow, everything is looking fine. You have done a fantastic trab. Everything is looking fine, but the bleb is not forming for reasons unknown to you, and it is getting clogged somewhere. Just to establish the flow, the internal helps really well. It is very fast, and it is not going to produce any sort of extra blood in your bleb. That is. But if you attempt it late, maybe after 6 months, maybe after 2 years, but there is a recent publication where they have tried an internal bleb revision 7 years after the primary surgery, and they have showed good result. I am not very convinced with my approach.
And one
Azim
point
sir,
I'd like to
just
make,
one-
Ajit, yes, regarding
Yeah.
this, we often have this concept that post AGV we can't, or a post barbell, we can't do a trap. But there have been cases where we have done AGV and it has failed, and we can see that maybe nasally you can still have some conjunctiva, and we have tried trap, and luckily it has worked. So that also can be an option at times.
Thank you, thank you, thank you. Thanks to all the speakers, and special thanks to Sir for giving us the keynote lecture, as well as giving a lot of insight into something which is being done in Brunei, which we were not aware of. Thank you so much. Thanks
Thank you,
to each and
Richard.
everybody.
Thank you, Richard.
So we conclude this talk. Thanks a lot for the audience.